Thank you, Chairpersons Professor Shubhankar Chaudhary and Professor Nilavani. It's a great honor for me that I have been invited to give a talk on lymphocytic hypophysitis by Endocrine Society of India. So I am especially thankful to Dr. Sapreshi. So the topic which has been assigned is the how do you approach a patient with lymphocytic hypophysitis. So let me start with the case scenarios. Okay. So 30 years lady who presented with headache for 3 months. She had some visual abnormalities and complained of fatigue. She delivered 6 months back. It was a vaginal delivery, but she did not resume cycles after that. She also had history of some polyuria and nocturia for 1 month before presentation. There was no past history significant. Clinical examination was normal, except her BP was 100/70 and there was a postural drop. On doing a visual field testing, she had some mild left temporal field defect. So with this history, we know she had a prop field defect. She had some weakness which could go with the cortisol deficiency. She also had polyuria polydipsia. It means she had, if we combine these three, and everything had started 6 months after delivery. So possibilities which come to our mind is, first is a pituitary mass. Why pituitary mass? Pituitary mass as such, or mild pituitary apoplexy? Because pituitary mass is more common. So if you make a common diagnosis, so you should do that. So pituitary mass, it means she has both anterior as well as posterior pituitary involvement. Next possibility which can explain everything is hypophysitis. Third possibility is, although Sheehan is quite common in our country, but it's a chronic Sheehan which we are used to see, but sometimes the presentation could be like acute Sheehan. I will discuss slightly in between how does it come in the differential diagnosis. So with these three differential diagnoses in mind, so we went ahead with the investigations. So glucose was normal, 80, slightly on the lower side. Sodium and potassium was normal. Anterior pituitary functions and other hormones revealed low T4 with an inappropriately normal TSH. FSH was low, LH was low, she was still amenorrheic, cortisol was low, IGF-1 was low, prolactin was slightly on the higher side. Because she had a polyuria, we did an osmolality, serum osmolality was 290 milliosmoles per kg, which is on the higher side of, and urine osmolality was only 130 milliosmoles per kg. So summarizing these investigations, this lady had thyrotroph, corticotroph, gonadotroph, and somatotroph failure with upper limit of prolactin concentration, and she also had central DI. Although we have not given vasopressin here to see whether she has a nephrogenic DI or a central DI, but because she had a pituitary, anterior pituitary dysfunction, we have to believe that this possibly is, we are dealing with a case of central DI only. So next, in endocrinology, after you make a clinical diagnosis, would be if you think of a pituitary disease, MRI would be best. So we can see on this MRI that there is a diffuse enlargement of pituitary gland. Also, this is a post-contrast MRI. Stalk is absolutely in the center and stalk is thickened. There is no erosion of the floor. And there is a intense and a diffuse and homogeneous enhancement after the contrast. So this is typical of a hypophysitis. So if we now go back to the differential diagnosis, we had initially made possibilities of pituitary adenoma, lymphocytic hypophysitis, and acute Sheehan. But now, after these investigations, the things will reverse. Lymphocytic hypophysitis would come first, in view of clinical picture and MRI. Acute Sheehan, less likely because I will be discussing one or two slides. Posterior pituitary involvement is less common in Sheehan, and corticotrophs may be preserved in Sheehan syndrome. Pituitary adenoma is less likely because we usually don't have a DI in pituitary adenoma, and imaging is typical of lymphocytic hypophysitis. This slide I am showing in between just because I had put one of the differential diagnosis acute Sheehan. So this is the study of serial MRIs done in patients who develop Sheehan. So this is a 1 week after the delivery. You can see without contrast, there is an enlargement of pituitary and there is an enlargement of stalk as well. But if we give contrast, it is a what is known as a hook-shaped enhancement, but in the center there is no enhancement. It's only enhancement of the rim. 1 month after the delivery, the pituitary is getting now shrinking gradually, and by 5 to 6 months, it forms a typical what is known as an empty cella. So if we see a patient here, or if we don't give a contrast, sometimes we can be confused with an enlargement of pituitary and a stalk thickening. We can say it can be confused with lymphocytic hypophysitis. Two things I want to, just two slides which are slightly away from the topic is, we said hyperprolactinemia is not seen in Sheehan syndrome. That is right. It is rare, but if you see hyperprolactinemia in Sheehan syndrome, it has been reported. We have reported it, so it should not surprise. Another possibility, posterior pituitary function, we know it doesn't happen in Sheehan, although mild posterior pituitary function is reported in 5% of the cases, but severe DI which needs treatment is not seen. It is restricted to case reports. We have reported a patient of Sheehan's with DI, and this reference is already in the Williams textbook of endocrinology. So going back, our first possibility was lymphocytic hypophysitis, anatomically 3 types. Whether there is involvement of anterior pituitary or posterior pituitary or whole pituitary is involved. So accordingly, it's anatomically named. It can be called as adenohypophysitis, or if stalk and posterior pituitary is involved, infundibular neurohypophysitis. And if anterior as well as posterior as well as stalk is involved, is known as a panhypophysitis. Adenohypophysitis is quite common. Other two are not so common. So there are many types. It can be primary, it can be secondary. Commonest is a lymphocytic hypophysitis, which we will be discussing. But there are other types, causes like granulomatous, xanthomatous, necrotizing, IgG, IgG4 related, and immune checkpoint inhibitor related. Secondary could be because of sarcoidosis, tuberculosis. We have seen some cases of tuberculosis presenting as hypophysitis. Similarly, collagen vascular disease, vaginal granulomatosis, Langerhans cell, histiocytosis, syphilis, and COVID-19. Riaz has recently, what Professor Chaudhary was saying, he recently published a case of lymphocytic hypophysitis following COVID-19. So lymphocytic hypophysitis, we know it is an autoimmune hypophysitis. It's most common. It's a rare disease. We don't see it so commonly. Initially, it was described in 1962. In the first 2 decades, only 16 cases between 1962 and 81, because possibly that time MRI was not available, because MRI is the investigation of choice and it shows the features. So once the MRI became available, the cases of lymphocytic hypophysitis reporting increased. Now people don't take case reports, but cases are seen and series are being published. It's more common in women, and almost 30 to 70% are related to pregnancy. It means it occurs either in the late pregnancy or in the immediate postpartum period. So we know it has an autoimmune etiology. There's a diffuse infiltration of the gland, lymphocytes, both T and B lymphocytes. So initially there is an infiltration only, but ultimately there is fibrosis. Some people say that because of increase in blood flow during pregnancy, more systemic blood flow, some antigens may be released from the systemic circulation, and these might lead to sort of antigen antibody formation. Some antigens might be released from the placenta. So these are theories only. Nobody knows what is the exact trigger, what happens in this lymphocytic hypophysitis. So this is the slide which we have seen previously also. It shows the close association with pregnancy. This is the time of delivery. So it happens either before delivery or maybe 2 to 3 months after delivery, symptoms will start. It is also associated with other autoimmune disease like autoimmune thyroid disease or type 1 diabetes, autoimmune Addison's disease. So you can have other systemic manifestations like vitiligo, myasthenia gravis, pernicious anemia, SLE or primary biliary cirrhosis. So this is the picture. On the one side we have a normal pituitary gland, and other side we have a gland which has a lymphocytic hypophysitis because of enlargement of pituitary. You can have a superiorly, if it enlarge, you can have a compression of optic chiasma. So visual disturbances are there. So there could be compression of pituitary stalk causing hyperplaquemia. Internal carotid arteries could get compressed. Diaphragm gets compressed, causing headache. There is damage to the pituitary cells, causing panhypopituitarism. Compression of third, fourth, and sixth nerves can cause diplopia. So compression of first and second division of fifth nerve causing orbital pain and facial paresthesia. And sometimes in severe cases, there can be compression of cavernous sinus as well. So this depicts what could be the signs and symptoms. So we know this is the mean age, 35 years, 35 to 40 years. 40 to 80% will have a hormone deficiency. Mass effect is again seen in a wide range between 25 to 83%. Many people have headache and visual abnormalities. So you can have a corticotroph failure, you can have a thyroid failure, you can have a gonadotroph failure. Hyperprolactinemia is quite common, but later on you can have hyperprolactinemia also. Growth hormone deficiency is also not so common. Central DI is seen almost in 40% of the patients. So this is, as I said, there are 3 types of hypophysitis. This is the adenohypophysitis, this is infundibular neurohypophysitis, and this is the post-hypophysitis, panhypophysitis. Headache and hypocortisolism are more common in anterior hypophysitis, whereas polydipsia, polyrate, it is because of this thing, infundibulum and stalk involvement. It is more common in infundibular neurohypophysitis and posterior hypophysitis. Other features like hypothyroidism, hypogonadism, and sometimes lactation failure can, in between it can happen. So these are seen almost in all the 3 types of infundibular types of lymphocytic hypophysitis. So once we have made the diagnosis, I think we need to rule out the secondary cause. For that, we need to do a chest X-ray, Monto's test, ESR to rule out tuberculosis, ASW to rule out sarcoidosis. Some people do anterior pituitary antibodies, rarely done in clinical practice. Anti-TPO commonly done, rule out a thyroid, autoimmune thyroid disease. ANA, dsDNA, ROLA, NCA, and PANCA rule out ANCA and PNCA rule out collagen muscular diseases. CSF analysis sometimes is required. Pituitary antibodies, as I said earlier, that people don't do it. It is a very low sensitivity. You can have a false positive in Sheehan also, empty cell also, Cushing's, as well as autoimmune thyroid disease. So MRI is classical. I have shown 3 pictures here. This picture is the post-contrast film of lymphocytic hypophysitis. You can see enlargement of the pituitary, the diffuse and intense enhancement. This is a sagittal view, pre-contrast. This is the pituitary gland which is enlarged, and you can see this is the stalk. This is thickened. This I have taken from my friend Dr. Riaz. Professor Chaudhary has already reviewed this while sending it for publication. So another, if we give a contrast, then there is an intense uptake, and it's a homogeneous uptake. So differential diagnosis, which I gave initially, almost same. It could be it could be acute or subacute presentation, which we don't see so commonly. If it is acute presentation, apoplexy, yes, can come in the differential diagnosis. Acute Sheehan can come in the differential diagnosis. But we are more often used to seeing chronic lymphocytic hypophysitis. It could be confused with chronic Sheehan or pituitary adenoma, germinoma, or craniopharyngioma. So these germinoma and craniopharyngioma can be associated with DI as well. So this is this table which we put last time, published it last time. See, this is Sheehan syndrome and lymphocytic hypophysitis, because once these people come to us, that time we don't have, I mean, everything is common in them that time. So if we see commonality, Sheehan is common in our country, in developing countries. Lymphocytic is common in developed countries. So if we see the patient population, Sheehan is seen only in women, but lymphocytic we can theoretically see in men, women, as well as in children. Association with other autoimmune disorders, usually Sheehan is not associated, whereas lymphocytic is associated. And Sheehan usually follows pregnancy. Lymphocytic also follows, but it can happen otherwise also. PPH is seen in Sheehan. It is not required for lymphocytic. Common trophic hormone deficiencies in Sheehan's are lactotroph, thyrotroph, and somatotroph, whereas common or the first abnormality in lymphocytic is corticotroph and thyrotroph. There is a preservation of hormone excess in Sheehan. Mostly, if there is preservation, it is mostly with gonadotroph and corticotroph axis, whereas somatotroph and gonadotroph can be preserved sometimes in lymphocytic. Hyperprolactinemia is not a feature of routine Sheehan, whereas it is a feature of lymphocytic hypophysitis. DI is very, very rare in Sheehan, whereas it is common in lymphocytic. And pituitary MRI shows empty cella in Sheehan, and lymphocytic hypophysitis, initially there is a pituitary mass with a contrast enhancement, but ultimately it may also present with empty cella. So we need to have a high suspicion. So it has to have a temporal relationship to the pregnancy. So once we see an MRI and we see severe hypopituitarism, but the mass is not so big, we should think of a lymphocytic hypophysitis. So definite diagnosis, histopathology, which is not required and which we don't do. So this is almost a similar table, but here I just have put some features on MRI, like gland enhancement on giving a contrast, or gland enlargement. Sheehan, you can have a symmetric enlargement. Same is true for lymphocytic, whereas in pituitary mass you have an asymmetric enlargement. Star thickening is not seen in pituitary mass, seen in this. Enhancement pattern, you can have a ring or hook enhancement in Sheehan. You have a diffuse enhancement in lymphocytic hypophysitis, and you have an asymmetric, there is no enhancement in pituitary mass. Posterior pituitary signal is present in Sheehan, it is lost in lymphocytic, and usually present in pituitary adenoma. Empty cella and follow-up happens in Sheehan also, usually happens in lymphocytic also, and does not usually happen in pituitary adenoma unless there is apoplexy and then secondary empty cella. So because most of these patients would sometimes go to neurosurgeons. So some neurosurgeons wanted to know whether we should avoid surgery. So what are the factors which we should know before patient goes for surgery? So they have given this is a Gutenberg scoring system, is given by neurosurgeon Gutenberg. So they have given some negative points and some positive points. If you have more positive points, it is more in favor of a pituitary mass, pituitary adenoma, so you can go for surgery. If you have more negative points, it goes more in favor of a lymphocytic hypophysitis. I will just briefly give, suppose age less than 30 years has a minus point, so more chances of a lymphocytic hypophysitis. Similarly, loss of posterior pituitary bright spot goes more in favor of a lymphocytic hypophysitis. Thickened stalk, it has a very high value and it goes more with lymphocytic hypophysitis. But if you have a saphenodal mucosa thickening, it goes with pituitary mass. Similarly, if you have a big mass, more than 6 centimeters, it goes with a pituitary adenoma. So because lymphocytes usually happens in relation to pregnancy, so that also goes with lymphocytic hypophysitis. Score of more than 1 means adenoma, less than 0 means an autoimmune lymphocytes. So it has a sensitivity of around 92% and specificity of 99%. So what are the treatment options? There are 3 options. One is just watchful waiting, which most of us do. Second is we can give immunosuppressants. First we give glucocorticoids. Somebody doesn't tolerate or somebody doesn't get with steroids, we can give any of these methotrexate, azathioprine, rituximab, inflammation. Theoretically, people have given it. Surgery, I will talk later on. Surgery has a very few indications. So if there is some drug which cause lymphocytic hypophysitis, so that has to be done. Radiotherapy has a very limited role. Steroids is the treatment of choice. It decreases the size. We also need glucocorticoids to replace because they have this thing adrenocortical deficiency. So we need to give glucocorticoids, but it has a less benefit later on because there is a fibrosis sets in. Its improvement occurs in 60 to 70%. Surgery should be only done that if there is no improvement initially, or later on follow-up, that patient is not responding, mass is not coming down, and there are visual disturbances. So that is the indication. Otherwise, nobody needs surgery. Radiotherapy not needed. Immunosuppressants, if somebody doesn't respond to steroids, these can be given. So this is the suppose if we talk of regression of mass, regression of symptoms, and what is the recovery and what are the complication rate. If we compare three, suppose symptoms of expanding mass, obviously after surgery resolve immediately. Steroids would take a 1 week, and if we just wait and watch, it would resolve within a month. So mass regression median, this is the median time. It happens in 1 to 2 years in both steroid and wait and watch group. So how many percent of people have a recovery of axis after surgery? 20%. Steroids, it is said everybody, and wait and watch 33%. Complication rate, obviously it will be after surgery only. So surgery is not routinely needed unless cranial dysfunction is present at presentation or during the time course. So what is the outcome? Spontaneous remission occurs in 3%. There is a need for replacement. Almost 70% of the patients would need glucocorticoid replacement. Surgery is needed only in 16%. So this is the just one slide before I conclude my talk. So if we think of lymphocytic hypophysitis, you assess the severity of hormone deficiency and also look for mass effect. If there is adrenal insufficiency, you replace it. Then you need to evaluate anterior and posterior pituitary functions. To other laboratory tests to rule out secondary hypophysitis. Go for an MRI and steroids. If you think there is a compression of optic chiasma, so steroids could be given. If somebody responds, taper the steroids and maintain on glucocorticoids. No response, could be given immunosuppressants, rarely surgery. To conclude, lymphocytic hypophysitis is a relatively rare disease. It is related to pregnancy. It is diagnosed of exclusion because it's not a common disease. So medical management is the preferred option. Surgery, only very few patients will actually need surgery. So with this, I thank the chairperson and the audience. So with this, I take a leave. Thank you very much.